don't think I knew everything that the job entailed when I decided to go into this field. I had an idea, but it grew on me as I went into it. And I would say sometime during my first year of my residency is when I realized I was in the right specialty for me.
Honey,
Don't.
we're not doing that. Will you just like vet wrap below it? Like you would a second piece of tape below and above it. Try and keep her from ripping that one out. You're okay. We're gonna get you some flow by. You, thank you. Look at how much she backed out more. Beautiful.
All right, give that midazolam.
First tiny bit you can give slower, but then you can just do nice steady push after you get about 0.2 into her body. There you go. Now you can. Beautiful. Like a professional.
Here's a little bit of flush.
I'm trying to take another one, but I'm waiting on these guys next to you. We're doing a rectal bleach.
Is she intubatable, you think, yet?
I think so.
All right, cool. All of her drugs have now hit her.
Yeah.
All right, you're going to stand there. That is the tube tie. I'll hand that to you.
May I have something?
There you go. That has gunk on it. I got one right here.
Got you.
Here you go.
All right, you might have to lean more towards this side over here. Yep.
I have propofol on standby if we need it.
If you need Asia's help to be able to see, let me know. Nah, that looked like a nice tight fit.
Oh, heck yeah.
Love to hear that. All right, now because she is, again, it's a little bit hypoxic, we are going to breathe.
I'm giving her a little bit more propofol.
Okay, so right now I'm just breathing off some of the CO2. We can do a leak check here in a second.
When we intubate a patient, this goes in just past the larynx, and the anesthesia circuit will be connected here, and you'll give the patient a slight breath, and if this has any gaps around the endotracheal tube here where the cuff is, air will leak out of it and you can feel that and hear that. So we'll slowly inflate this, we'll put a little bit of air in the syringe, we'll give the patient another breath, and then we'll keep doing that until the point when we don't hear any air escaping around the cuff. And that's how we check for a leak around the endotracheal cuff.
Okay, you ready? Okay. Breathing, breathing, breathing. Very small leak, I think could be resolved with 1 ml of air.
A little bit more.
Okay, let me fill it back just a sec. Breathing, breathing. I am able to hold at 20 seconds.
All right, cool. Systolic and diastolic is too close together. So what Melissa probably just did now, she probably clamped it off, and I think she grabbed a flush syringe, and she's going to try to flush through the art line, see if there are any clots in our way.
Okay.
It looks the same. Yeah, I don't know.
So I'm starting on the
But the oscillometric is reading great, so I'm not concerned. Did we paralyze already?
No.
Okay.
Nope. But I usually wait till they are like, go ahead.
Everything looks great. Are you on the vent yet?
I am just on ventilator assist.
All right. I try to remind everybody that you have to enjoy what you're doing. And one of my rules that I tell people is if you're not laughing, you're doing it wrong. And even in the most stressful moments, in the most difficult cases, you have to be positive and you have to try to keep it together. If the anesthesiologist or the anesthesia people in the room are panicking and freaking out, the surgeons and anyone else that's doing their stuff quickly spiral and also panic, and that can lead them to rushing or hurrying things even more so and possibly creating mistakes. So it's really important that we stay calm and relaxed as possible and just try to keep on moving through each case. But I think just try to smile and have fun and do the best that you can. If we use methadone, we don't need a bolus of fentanyl. Okay. And then lidocaine, we'll give them a mg per kg bolus. I usually just have the syringe pump do it.
Okay.
I don't pull up
Don't
extra
draw.
syringe.
Yeah.
It just, if it's in the syringe, I can just tell the syringe pump, give this bolus, hit start,
Yeah.
and then it continues the CRI right afterwards, and it just is easier.
Sounds good.
Especially when I'm here like after hours, like and stuff, and you're doing it like mostly by yourself.
Yeah.
Why pull up multiple syringes and do more things with your hands when you can just hit a button
Right.
and then actually take care of the
Yeah, no,
patient?
that makes
So
sense. And you want us to start
I know
those right away?
what I would get them induced, and then I would go ahead and get them started
Yeah.
as we're getting ready to roll in and stuff. Hopefully having those on board means that we can run a little bit less gas anesthetic and stuff
Yeah.
like that. So
Sounds good.
just in case he does get hypotensive,
Mhm.
I'm not anticipating that. This will be fine. Again, I just want to know what we're dealing with as far as management goes.
I was just gonna ask you, is it worth it? Really hard not to.
You're going to room one. When we're working with the students, one of our primary goals is to make sure that they get to work with all of the current drugs that are available to us. And we want them to be familiar with them and comfortable with them and know what to expect with them, so that when they leave here and graduate and they go out to other practices, our goal is that hopefully they can take the newer knowledge and some of the newer drugs and techniques that we do into those practices, just to elevate the level of medicine that everyone's doing a little bit every year. And so one of my goals is to encourage the students to make sure that they're using a variety of different drug combinations. Propofol and ketamine is one of those drug combinations. It was taught to me by Dr. Wilson, who's still on faculty here. And so it's still a drug, as a student, I learned about that protocol. And so I still use it to this day when it's a right for that appropriate patient. Have you done anything with propofol ketamine yet?
No.
Why don't we do that?
Okay.
This is a relatively healthy patient here from ortho thing. I think this is a good time to do propofol ketamine. I still want you to do afaxolone by itself and do at least some more afaxolone midazolam, but this is a good patient to try propofol ketamine on.
Okay.
And I'll give you an option. There's two ways you can do it.
Okay.
You can do it just like propofol midaz, so propofol mg per kg, ketamine 1 to 2 mg per kg, more propofol do effect. Or we can do what we refer to as ketofol, and we can mix 3 mg per kg of each propofol and ketamine into one syringe, and you give it to effect like it was propofol by itself. So I'll give you the option of one of those two.
I'll do the second one.
You want to do the ketofol?
Yeah. Setup checklist. Yes, we're all set up. Tubes, everything. Got my tie. Drugs calculated for emergency. Yes. Critical events. No. Antibiotics. Yes, and we got them.
Yep.
And then NSAID. Yes. Okay. Done.
Alrighty.
Okay. I usually like to lube a tube before I start, just because I'm like slow. I don't know which one we most like.
Got the lube right there.
Yeah,
ready to go.
we can wait.
Okay.
We can take a look and see what his trachea looks like.
The trachea.
Trachea. Are you okay doing a lateral intubation, or do you want me to sit him up?
Lateral's fine. I did
Okay.
that yesterday.
Great.
Okay, ready?
I am ready.
Okay, so we're almost to like 11.
Mhm.
So I'll go to
The 8.
the 8. Okay.
Okay.
The fur right here.
Okay, buddy.
Okay, ready?
Might need a little bit more.
Okay.
What do you think?
You think 3 more or a little less?
Let's just start giving a little bit and see where we go.
Like 1.
Yeah, 1 or 2.
And one thing I remember was anatomy is they're gonna retain some of their reflexes.
Okay.
So like history.
I know it had a space, and that's all it was. They essentially what they found. I can have the student come in and do a little more round.
Yeah, because we
There
just
we
need
go.
either
Nice.
that. If,
All right, let's hook up to the oxygen there.
If he's got the history, maybe he has to come around Thibault and I just learn what's going on. Okay. But I've already had a student start work out. But he can come and stop by and tell us the main history of it all.
already
I'll get the
Mhm.
student.
is 1.5
So if
okay?
you want to do
Yeah, all we did was come in and like
a leg check, give him a couple breaths.
Is it on?
Holding it,
Kids
20.
come over and wake up or whatever. 'Cause
Okay, I'm not feeling anything. I just put a couple of mils in. So it feels great. All right, let's tie it in.
Yeah. So they're closing mine right now, so it should be.
You're gonna have to probably lower this a little bit. So we use a nerve simulator and a needle with local anesthetic, and we find the nerves, and we inject local anesthetic around the nerves of just this one leg. So we're only affecting the one leg. And then the next level of the gold standard would be a nerve simulator with an ultrasound, so we can see the nerves and know we're close to the nerves, and we still use less anesthetic, but we still target those nerves, and we're not poking inside of them. So
What's
that's
that
the gold
close?
standard. 8.5, whatever you grab out of there. Sciatic nerve is the 2 dark circles and immediately in the middle of the screen. Let's go ahead and aspirate here. Actually, turn that up just a little bit more, with like 0.6 or so. Yeah, I like that. All right. So we're going to slowly start injecting. We're going to do about 3 around this nerve.
Okay. Injecting.
Yep. Should start going pretty. There we go. We see a nice little pocket forming. Keep going. Yeah, we're good. We're on top of that nerve. Just moving my needle around, spread it around. Nerves right there. Poke. Poke. There's the nerve. Poke. More of a boop, not a poke.
If you want to
trying to
mark
remember
the
what their doctor words
ropivacaine,
are.
Abductors and
and also you can make an anesthesia
And then just come a
event
little
that
more
we're
towards you, like,
blocking.
that way. Right about
And you
there.
guys are doing how much for protein
7 mLs.
of the
Just don't let it
No, you're
go.
doing
It's 10 mg per
Said
mil, so
10
70
mg per mil.
milligrams. This is why it's one of my favorite things to do. I'm gonna go up, boop, boop. There's the nerve right up there. Boop. It looks a little bit different. This has like hypoechoic stuff around hyperechoic, so dark shadows around the bright.
Going through the line.
Yep. And then I'll let you know when I see the air. Perfect. All done. You can rehang and finish. A successful case is a case that recovers well, smoothly. We have good control of their pain and analgesia, and is heading home within the next day or 2 after the procedure. That is a successful case for me, regardless of how complicated or how difficult it is. To me, that's success. Our other successes that we're always doing at the same time is just educating other doctors, educating interns and residents, training nurses and training students. Those are other successes that happen at the same time. But when it comes to an anesthesia case, smooth, uneventful recovery, and they get to go home with no complications. What keeps me motivated is a variety of cases and honestly the students. And the students are very nervous when it comes to anesthesia, and there's a lot of hesitancy, and I just like seeing them come through, being a little scared when they first start with us, and then just get excited about what they're doing and working on their patients, and knowing that they do have the skills and the knowledge to do the work that they need to do when they graduate. And I like seeing that growth and development.